remote surgery. So we tried very hard to manage a valve for him, and at the end we were able to manage fund for him. So this is the procedure of this boy, pre-dilatation with coronary angiogram we are seeing, and also the checking of the coronary arteries. Now this is the pre-stenting we did with the 2 covered stent, and then this is the placement of the Melody valve. And the Melody, the authority, they also certified this case as the first one in South Asia. So what was the problem faced during doing this case? There was no CMR at that time in our country, and we were actually selecting the case using only echocardiography, and then with the CT angiogram, and also with the cardiac catheterization. So we assessed the RBT finally in the cath lab by balloon interrogation. Supply of hardware was very difficult at that time because nobody was supplying the valves in our region, and funding for the valve was another problem because this valve, you know that this is very expensive, and at the same time the covered stand, these are also very expensive. And there was procedural challenge also, as these cases are very infrequently done, so you need to train your cath lab staffs, and you need to have supply chain or uninterrupted supply chain for all the hardwares which you need for the procedure. And supplier challenge is that there is no local agent, so they are also not actually feel free to supply these products in country where there is no local agent. And fund collection was also very difficult because in our currency it took like 30 lakh Bangladeshi taka for a single procedure. So our policy was we accepted the cases with conduit dysfunctions only, and there were many cases with bare RBOT. They also required this procedure, but initially we thought that we should do the one which are good as a first ones. So if we see the patient data of the 10 cases in our series, their age in average is about 9.5 years, their weight is around 28.75 kg, and types of the conduits used during the surgery were aortic homogram in most of the cases. And in some of the cases there are pulmonary and bovine pericardial valve conduit. Primary disease was tetralogy fellow in 33% cases and pulmonary atresia in rest of the cases. In echo findings, pulmonary stenosis gradient was around 50, PR was free or moderate, and RV and diastolic volume was around 150 ml per meter square. And so these were the findings in all 10 cases. And during the procedure, we did the procedure, all the cases under general anesthesia. There are some additional problems in some of the cases like RPA stenosis, RPA and LPA stenosis. So we did the balloon dilatation or stenting at the same time. All the cases were performed through transfemoral approach, and in all the cases we used CP stent, but in only one case we used ENRA stent. Immediate outcome was very good. There was actually no significant gradient after the procedure, and there was no PR. So functional outcome of the procedure, there was a peak gradient, it was in mean about 9, and pulmonary regurgitation was trivial in one case only, and strand fracture not faced in any of the cases. We had infective endocarditis in one case, this is the case, and we treated her and she was cured. So this is her case actually, she was the case number 10, and this is the CT angiogram of her and procedure in the cath lab. So this is the case number 10, and we published also. So in conclusion, percutaneous pulmonary valve implantation is an excellent treatment option. Procedure itself is not that much difficult, but price of the device is actually a hurdle for the developing country like us. And we have one patient only who developed endocarditis, which was cured after treatment, and 2 of the patients after 4 years of implantation, they again developed stenosis, and we dilated the valve again with the Atlas balloon. Having said all this, we have stopped this procedure now because of the suppliers problem and of the financial crisis. Thank you very much for patient hearing.